You can use dopamine, you can use dobutamine. What else can you use? We have one more which is called angiotensin 2. There's only certain hospitals that actually have access to it. What you want to know is when you look at drugs like epinephrine and dopamine, it is actually dependent on the dose. If you start a patient on epinephrine, initially within the first 10 micrograms that you're doing, up to first 10 mics, it predominantly works on what receptors? Beta 1 receptors. After 10, going up to 20, it works on alpha 1. So know your pharmacology because that's how you know when to use. For instance, if a patient is on the floor and the patient's blood pressure is dropping, back in the day we thought that dopamine was the least corrosive of all the pressors. So we preferred to use dopamine via a peripheral line as opposed to norepinephrine or anything else. So the nurse typically will ask you like, hey, what do you want me to start the pressor at? And what has always been our typical answer? Start low and work your way up. But when you start somebody on dopamine, the first 2 mics, what does it do? It actually stimulates dopaminergic receptors in the kidney and increases urine output. A completely undesired effect that you're looking for. When somebody's in dehydration or in shock, your kidney is trying to preserve fluid, right? That's why your urine output is going down. You giving dopamine to stimulate dopaminergic receptors to increase urine output is doing you no good. So if you really want to raise the blood pressure, you need to know at which dose is it actually going to give you alpha 1 effect. So 0 to 2 works on dopaminergic receptors, increase urine output. 2 to 10 works only on beta 1 receptors and causes tachycardia. It's above 10 that actually gives you the alpha 1 squeeze. So you want to start them above 10 mics in order for you to get an alpha 1 effect with dopamine. Similarly, epinephrine is dose dependent. First 10 works on beta, after 10 works on alpha. You can use dopamine or epinephrine, but remember it's a dose dependent effect that you're going to get. Angiotensin 2 is another pressor that you can do, fine. Now when it comes to dobutamine and milrinone, these are inotropic agents. So they're not just inotropic agents, they are actually inodilators. They cause inotropy by stimulating the heart to squeeze harder, but at the same time, what do they also do? They work on beta 2 receptors and it's going to cause vasodilation. Because if you look at dobutamine, what receptors do they work on? Beta 1 and beta 2. Beta 1 in the heart is going to give you inotropic rate, increased blood pressure. Beta 2 in the blood vessels, what does it do? It causes vasodilation. That's why when somebody's got, say, cardiogenic shock, you're like, patient's ejection fraction is 10% and the patient is in shock, you're like, okay, this is cardiogenic shock. What is the first pressor you're going to start them on? You might think it's dobutamine, but dobutamine is going to worsen the situation. Why? Because dobutamine is going to stimulate beta 1 in the heart to squeeze it, sure. But at the same time, it's going to squeeze your beta 2 in your blood vessel, and the beta 2 stimulation in the blood vessel is going to cause vasodilation. I said, in your blood vessel, you have alpha 1, beta 2, M3. Alpha 1 causes vasoconstriction, beta 2 and M3 causes vasodilation. So if you stimulate a beta 2, you're going to get vasodilation. So if you start dobutamine in somebody who's in cardiogenic shock, without levorfed, without norepinephrine, you will risk the happening of worsening hypotension. So even in cardiogenic shock, your first line pressor is still going to be norepinephrine. Have you norepinephrine in first, then you can add dobutamine on top. Got it? Now you can always make an argument saying, well, in end-stage heart failure patients, they end up staying on dobutamine drips or milrinone drips by itself. Yes, that is true. But those patients aren't technically in shock state. If somebody's in end-stage heart failure, blood pressure cannot be maintained to a certain extent, yes, it does work as a good drug to inotrope, but end of the day, if somebody's going to be on dobutamine or milrinone, they have end-stage heart failure. Their prognosis is extremely poor. They need to get a heart transplant, if not, they're not going to live. But on the clinical context, if the patient is here and in shock right now, and the patient is hypotensive, and even if you think it's cardiogenic, you must start norepinephrine first. So those are all the pressors that you're going to play around with. Now when you start somebody on a pressor, what is the blood pressure target you're going to target? Yeah, so are you targeting systolic blood pressure, diastolic blood pressure, pulse pressure, or MAP? MAP, and the MAP should be greater than 65. And why is this 65? Who came up with this number? They looked into what are the perfusion pressures of the brain, what is the perfusion pressure of the heart, what is the perfusion pressure of the kidney. Pretty much most of them had a good perfusion pressure at 65. And that's why MAP of 65 is good enough. So say you start the patient on a pressor, What else are you going to be looking at in your patient to say, okay, I think I'm doing good. I think the shock is correcting. So you want the MAP to be up. Great. You expect the heart rate to come down. You're giving them volume to fill up the tank. What else are you going to look for in your patient?
Urine output?
Sure, urine output is a very important sign. So if somebody is adequately hydrated and the tank is full and your pressures are good, you're perfusing the kidney is no longer going to try to protect and prevent you from having and wasting all the urine, so you're not going to have to preserve it. So what is a good urine output to say that you are actually doing good? It's 0.5 cc's of urine per kilogram of body weight per hour. So 0.5 ml per kilogram of body weight per hour is your target. So if somebody was 70 kilograms, 0.5 ml per body weight, 70 kilogram is going to be 35. So 35 ml of urine output per hour is what you're going to expect. Now previously people used to do this thing where they gave dopamine to patients. They were using dopamine to increase perfusion of the kidney. Is that a good thing? Giving patients dopamine so you can increase your urine output. On the context of shock, no, it's not, because the kidney's job is to prevent you from peeing out the urine. The urine output went down for a reason. It's like, no, you're dehydrated, why am I peeing it out? I should preserve it. But you giving dopamine to push it out is not the right thing to be doing. So therefore, using dopamine to increase urine output, that concept doesn't exist. You have to naturally hydrate them well, have good pressors, and the urine output has to naturally go up. If it goes up, that's good. What about labs? What are you going to be looking at in your patient's labs to say, okay, our treatment's working? Okay, so when it comes to septic shock, you give fluids, we've spoken about that. We do pressors, we've spoken about that. What else are we supposed to be doing? Antibiotics. How soon should you be doing antibiotics? Within the first 1 hour of you seeing the patient, you better be starting broad spectrum antibiotics. When I say broad spectrum, if you have zero source when the patient comes in, because the patient is unresponsive, you don't know anything about the history, you're getting a UA, you're getting a chest x-ray, don't wait. Start broad spectrum antibiotics. What is a good broad spectrum antibiotic?
Zocin and Vanc.
Okay, so you can do Zocin, Vanc, you can do ceftriaxone. Normally, we don't want to over abuse antibiotics. We all know that. But when in doubt and you have zero source, you have nothing to go with, you want to cover the broad organisms based on patients. So covering MRSA or staph or Pseudomonas, if the patients had that before, if patients had past infections, you want to cover broader. But important thing is broad spectrum antibiotics within the first hour. Every hour that you delay antibiotics, what happens? Mortality actually worsens. So antibiotics for everybody, you're going to start broad spectrum within the first hour. What is the number one rule in septic shock management? The most important thing. Exactly, finding the source and source control. If it's a pneumonia, you need to address the pneumonia. If somebody's got an abscess, if you had a empyema someplace, or if you have an abscess, source control is the most important thing of the infection. Because as long as the infection exists, the problem will be ongoing. If there is something that needs to be drained, it needs to be drained. If you got C. diff, you want to treat the C. diff. If you have ESBL E. coli, you better be on meropenem. If you got meningitis, you better have meningitis coverage. If you have Pseudomonas pneumonia, you better be on Pseudomonas. If you have MRSA bacteremia, you better be on vancomycin. If you're not on the right antibiotic and if you did not control the source, that whole problem is going to keep going on. So the number one thing for you to do, not give fluid, not finish pressors and saying, okay, I'm good. No, get down to the source and find out where the source is. That's the most important thing. So say you do antibiotics, fluids, pressors, you're like, great, blood pressure is good. You come take a seat and you're like, I think I can take a break now and chill out for a second. Next thing you know, the nurse calls and says, hey, MAP is back down to 40. What are you gonna do? What's your next step after having done all of this good work that you've already put in? Stress dose of what? Steroids. So you want to give steroids to somebody who's actually septic, in septic shock?
All the pressors and everything?
Yes, you've given the patient fluids, you've given the antibiotics, now you're giving the pressors. Yes, so you want to immunosuppress somebody with steroids while they're in septic shock?
You may have some adrenal insufficiency.
So you think the patient might have adrenal insufficiency. Okay, why?
He's not recovering.
Okay, so given that the patient is in a very stressful state, His argument is, he's saying that the adrenal glands probably ran out of its cortisol because now it has been a sudden surge in requirement for the cortisol. Great theory. So why don't you get a cortisol level to prove it? Because you're going based on gut feeling and say, I'm going to treat it. Why not get a cortisol level to see, hey, cortisol is good or not? So you want to get AM cortisol. Okay, you can get AM cortisol, and if it's less than 3, it tells you it's low. If it is greater than 18, says there's enough cortisol. So the big question is, could adrenal insufficiency exist because of a septic shock patient? Is the answer yes or no? It is yes. What do we call this? It's called SVRI, corticosteroid insufficiency in the critically ill. There is a whole concept that this actually happens. Well, if we know the concept exists, should we test to see if the patient has cortisol insufficiency before giving them steroids, or just give it? The answer is